Hello friends, now I'll be seeing about choledocholithiasis. So before starting, I would like to share the notes that is given in the description below. You can download it from there from the Telegram channel. So without further delay, let's get started about choledocholithiasis. So choledocholithiasis is stone in the common bile duct, and the clinical features for this choledocholithiasis that it could be asymptomatic. It could present as intermittent jaundice, obstructive jaundice, and sometimes it may present with cholangitis with features of Charcot's triad, that is intermittent pain, intermittent fever with intermittent jaundice. It can also present more severely with shock and mental state disturbance, uh, mental state abnormality, that is the Reynolds pentad. And investigation of choice would be LFT, which would show raised bilirubin with rise in alkaline phosphatase. And along with that, in the imaging, we would see uh, through the ultrasound, there could be uh, raised bile duct caliber, that is CBD caliber. Though it is only the initial investigation of choice, the investigation of choice for choledocholithiasis is MRCP, that is magnetic re- magnetic resonance cholangiopancreatic echography. Then other helpful investigation is endoscopic ultrasound, which is especially helpful for CBD sludge or microliths. Then other lastly is the ERCP, which is also helpful as diagnostic and therapeutic technique. Then to see the management in detail, and choledocholithiasis has to be managed or presents in three situations, that is preoperatively with when the patient is being managed for cholelithiasis, or intraoperatively during laparoscopic cholecystectomy, or after laparoscopic cholecystectomy. So these are the three conditions, and we'll see the management of choledocholithiasis in detail. That is ERCP, that is endoscopic retrograde cholangiopancreatography, which is diagnostic and therapeutic. Other we have CBD exploration, which we'll see in detail, the laparoscopic and the open technique. In ERCP, endoscopic sphincterotomy with stone extraction, which is effective treatment, generally done in the pre-op setting to clear the duct stones. And if it is unsuccessful, then we go for uh, laparoscopic or open CBD exploration as per need. And most of the patient, that is more than 50% patient with ERCP without cholecystectomy, will have recurrent issues of the biliary tract. So we have to consider ERCP as the minimal invasive, non-invasive form of management for choledocholithiasis. Then some of the features or failures or causes of failure of ERCP, that is if the stone is large, especially larger than 2.5 centimeter and even more than 1.5 centimeter, altered anatomy, that is previous Roux-en-Y surgery, impacted stone, intrahepatic stones, and multiple stones. Then for CBD exploration, that is through the open and the lab technique, it is done through CBD exploration with T-tube insertion. It can also be done with choledochoduodenostomy, where we'll go for diamond-shaped anastomosis. Then CBD exploration with hepaticojejunostomy, where we have the root sleeve, Roux-en-Y hepaticojejunostomy. And lastly is the transduodenal sphincteroplasty, which is helpful for impacted ampullary stone, which is unretrievable through other methods. In a non-dilated CBD, then techniques for the stone removal is flushing through the forceps, through Fogarty's, or through the basket. Now something about hepaticojejunostomy, which has a better long-term outcome. Now we'll see the bilioenteric anastomosis in detail, that is useful or indications for the distal CBD stone which is impacted and having stricture. So that are the indications, especially dilated bile ducts, multiple bile duct distal CBD stones which are impacted, distal duct stricture with stones, intrahepatic stones, primary bile duct stones. So these are some of the indications for bilioenteric anastomosis, that is hepaticojejunostomy or hepaticoduodenostomy. Now we see the lab CBD exploration. It can be done through two methods, that is transcystic, and indication for transcystic lab CBD exploration is when the CBD is less than 6 mm, cystic duct is more than 4 mm, stone is distal to the cystic duct and CBD junction, stone size is less than 10 mm, and stone is less than 80 number. And for laparoscopic choledochotomy, if there is failed transcystic approach or ERCP, narrow tortuous cystic duct, stone more than 10 mm, stone more than 18 number, that is multiple stone, cystic duct that is smaller than 4 mm, CBD more than 6 mm, and proximal duct stone to CBD and cystic duct junction. Now, lap or open CBD exploration is superior to ERCP in CBD clearance without increased morbidity. But still, we can consider ERCP as it is minimally invasive and has good outcomes for CBD clearance. And also it can be tried multiple times before going for invasive approaches like lap and open CBD exploration. We have to consider the special scenarios in which we have to consider the individual case, that are gallstone pancreatitis, patient with cholangitis, pregnancy and retained stone. And we can also go for lap bilioenteric anastomosis in the form of lap choledochoduodenostomy and lap hepaticojejunostomy, which can be done end to end and side to side. So this was all about treatment of choledocholithiasis, and to just have a brief review of the three scenarios. So if we have found that in the pre-op setting during the planning for the lap cholecystectomy, we find that there is choledocholithiasis, we can go with preoperative ERCP with stenting if required, followed by lap cholecystectomy after 2 to 3 weeks, and after 2 to 3 weeks we'll go for repeat ERCP for stent removal or any residual stone clearance. In the second scenario, if we come to know intraoperatively during the lap cholecystectomy that there is choledocholithiasis or CBD stones, we can go for simultaneous lap CBD exploration along with lap cholecystectomy. If that is difficult, then we can go for open CBD exploration and if required bilioenteric anastomosis. And in third case, if after lap cholecystectomy the patient presents with obstructive jaundice and features of choledocholithiasis, we can go for laparoscopic or open technique of CBD exploration, and if required we can go ahead with bilioenteric anastomosis also. Also we can try for ERCP if the uh, conditions of the CBD and the stone permits us for ERCP, as it is the minimal invasive rather non-invasive technique for choledocholithiasis management. So these are the three scenarios which we can consider for treatment of choledocholithiasis, and hope it has been understood and can be utilized for writing the answers for DNB and MS surgery exams. So thank you for watching. Please like, share, and subscribe. Keep studying, keep growing, and never give up because great things take time. See you in next video soon. Thank you.